Okay, I will resume the recording now. Good morning, everyone. Thank you for joining us this morning. My name is Jackie Luxinger. I have the pleasure of coming to you from the Colorado HIMSS board and specifically from the Informatics committee. So thank you so much for joining us. And as you can see, we have a great panel with us today, and we're excited to talk with you a little bit more about overcoming challenges in healthcare interoperability. Again, thank you for joining us, and the webinar is being recorded for those of you who may want to refer to it later. We will have a little bit of time at the end of the session, so hopefully if you do have questions, please ask them. Also, there is a way in the webinar that you can ask a question. So if you go to the little bubble that says Q&A, type in your question. We have someone monitoring that. Also, if you have a question, you can use the chat function. We will also be monitoring that. So thank you for your time today, and thank you for joining us. I have the pleasure of introducing Helmut Oehring today, and you know, Helmut has done a great job of organizing this webinar for us. Helmut is the CIO of Ascend Clinical Lab. He has over 30 years experience in a multitude of things. Helmut, as I was reading your bio, it's like this guy's done everything: global supply chain, manufacturing, information technology, and he's the CIO for Ascend Clinical. So his role is really to implement those technologies and strategies for Ascend Clinical. And you may or may not know that, but Ascend Clinical is a clinical reference laboratory that specializes in testing services for kidney disease. And Helmut currently, his current initiatives, other than helping us put on these kind of great webinars, are to enhance healthcare clinic portal for direct physician and patient access, looking at advanced integrations with clinical EMRs, and leveraging AI to gain insights into extensive longitudinal data sets and automating the laboratory with robotics. So busy guy, Helmut. We're so pleased to have you on the panel today, and thank you for agreeing to be our facilitator. I'm going to turn it over to you to introduce our panelists for today's discussion.
Thank you, Jackie. Welcome to everyone on this snowy Colorado morning. Thank you for taking the time away from your very busy schedules. As I was working with the panel to make sure we are tackling topics that are relevant to each of you, I recognize many of the topics that we're going to talk about today that my own team is wrestling through and trying to achieve our interoperability within Colorado, but we're also our range and extend across the nation. So we're going to talk about some things that might be very specific to Colorado, but I think we're going to leverage some concepts and solutions that we can use on a national basis. And preparing for the webinar today, I was trying to find some good experts in these topics, and I'm really excited to go through these introductions. I'm going to read through them, so I'm going to be a bit robotic, but I want to make sure that I get them right. So first joining us is Dr. Brian Levy, and he's an executive healthcare physician with deep expertise in creating software and content. He currently works for Cerner on the VA and DoD implementation and focuses on interoperability and terminology. Previously, as the chief medical officer, he helped lead Health Language from a healthcare IT startup to successful acquisition. And he continues to practice telemedicine using the latest technology and delivering everyday patient care. He also serves as the Colorado HIMSS Advocacy Chair. So welcome, Brian. We also have with us Herman Östervik, president of OT Consulting. Herman is a healthcare imaging and IT trainer consultant with expertise in interfaces between medical devices and software through his participation in standardization committees such as DICOM, HL7, and IHE. He has authored several textbooks and numerous articles about healthcare IT and on the subject of picture archiving communications systems and the digital imaging and communications in medicine, both PACS and DICOM standards. He recently finished his tour of duty as the co-chair of the HIMSS interoperability and HIE community. So welcome, Herman. And then finally, Ako Kwame is the Vice President of Data Management at Creo, which is now part of the Contexture organization. Ako has over 15 years of experience working with many segments of the healthcare industry, including health systems, physician organizations, insurance providers, regional provider alliances, and clinically integrated networks. His work is concentrated in enterprise and service line strategic planning, partnership transaction planning, and a design and execution of a wide range of healthcare information technology products and services. In addition, Ako has extensive experience implementing clinical integration programs, electronic health record systems, and quality reporting systems focused on population level health improvement and development of capabilities required to succeed under value-based payment arrangements. So welcome, Ako. So I think you recognize that we have a lot of expertise in a number of different disciplines and a number of different organizations. So I'm excited to walk through these points in our presentation today. We'll make the video available as well as presentation material available after the webinar is completed. But Brian, maybe I'll ask you first this question. We have a good, solid healthcare interoperability environment within Colorado, spanning most of the key business processes from telemedicine, ADT orders, referrals, and extending into side parts of our healthcare environment with the VA and DoD. But can you share which new interoperability initiative in 2021 you feel made a substantial impact to patient care and/or physician engagement?
Yeah, I think a couple of thoughts there. You know, putting my Cerner hat on, I'm working across the country with the VA at a national level. As many of you may know, all the VAs in the country are converting to Cerner, as well as all the DoD sites. So we haven't gone live yet here in the state of Colorado, but hopefully with the next couple of years there. But, you know, what that's going to mean, I think, is a couple things. You know, one is, you know, greatly expanded interoperability between active service people and when they transfer over to the VA, and, you know, great increase in interoperability with the community. I know, you know, when I was seeing patients in the clinic, it's always a struggle because we see a lot of VA patients, and how do we share those records? And so we're not quite there yet, but I think we're moving in that direction. So I think that's certainly one of the themes.
Thank you. Ako, I know that you referenced that CRISPR is kind of phased out last year. Do you see any other the next level of integration or interoperability phasing happening in any of these areas?
Yeah, I do. You know, in Colorado, we are investing and looking at the social health information exchange. I know many organizations and groups are involved in that right now, and I do think the integration of social data in HIE data or in clinical data has always been the, a huge gap. Obviously, physical health, behavioral health, social health, that information has traditionally been in silos. And so the ability to kind of take a look at that information and incorporate that with the appropriate data sharing agreements and rights and permissions, of course, it's going to be, I think, fascinating for Colorado, and Colorado is always a leader in those types of technologies and integration systems.
And Brian, if I am remembering correctly, or still a practicing physician, how have you seen telemedicine be embraced by the patient population?
Yeah, so, you know, certainly the virtual medicine space is kind of out of the bag. I started seeing patients virtually before the pandemic, and got involved with some of the national sort of urgent care telemedicine providers such as MD Live and American Well. And then, of course, you know, now the cat is sort of out of the bag. I think there's a couple ways to think about it. One is certainly you're now more and more seeing your own doctor via the telemedicine platform, which is great because then your individual doc is sitting in front of their EMR and you have the interoperability and connectivity that their EMR offers them. But the challenge is that we still see a tremendous number of folks come into this sort of urgent care platforms like MD Live. I see lots of those patients. And when they do, I have almost no information about the patient. Occasionally, we're able to get a CDA, which is quite frankly not that helpful. Occasionally, we fax a summary of the report back to the PCP, but overall, there still is this lack of interoperability with these telemedicine platforms. And so, hopefully over time, for example, maybe we can see sites like MD Live actually hook up to the HIE so that we can more readily share this information back and forth.
Very interesting. As I work with some of my other peers here in the Colorado area, I received a common thread about some of the existing inefficiencies and challenges as it relates to connecting data, but also the participants in the healthcare environment. One in particular is these lab results needing to go to various parts of the healthcare caregiving team and to try to match up the results to patient records that are not as readily available or accurate. And then I think the silos that you were referencing, Brian and Akko, for care coordination, whether it be the urgent care environment or social services, I think that there's a vast break between the multiple parts of the caregiving team. And then interesting, from a technology perspective, there's continued frame of reference as it relates to is fax technology archaic, or is it really the safest way to communicate? So Herman, what do you think about those challenges, and have you seen those yourself?
Yeah, so I had the opportunity to listen to one of the presentations at the HIMSS Interoperability Showcase. By the way, if you haven't seen the Interoperability Showcase at HIMSS, if you're going to be visiting in Florida, I would urge you to look, to look at that, because it shows really how these systems are being connected. But anyway, so there was a presentation in Vegas in August, and I happened to work for them. And the presentation said that 61% of the people that responded in the survey was more than 1,000 people, 1,000 providers. 61% still use fax today. Isn't that amazing? And another question in that survey was that at least 50% will consider faxes valuable as a valuable or dominant exchange information for the next 5 years. So here we are. And as you know, I think so. Faxing is really convenient, because what you do, you get your piece of paper, you put it in a fax machine, and there you go. But it is very short-sighted, because on the other hand, what is the person going to do? Take a piece of paper and maybe scan it into a document, and the document goes to the EMR, which is unstructured. What can a physician do with it? So let's say you have a physician in EMR, and he has to flip through all of these documents that were scanned in and attached to this patient. That is extremely inefficient. So what we want a communication means that is structured data, takes the lab results, or the report, or the observation, or the diagnosis, or the medications, and one by one takes that structured data, nicely populates it in our EMR, so it is at the fingertips. Why is it that we still use faxes? I think, and what's interesting, it was really not a uniform one particular reason in that survey that was done. It's a complex ease of use, security, whatever. But I think we need to start thinking about what we create. We create unstructured, unmanageable data that is not easy to use. So let's try to change that. Let's try to change that. Thank you, Helmut, for asking.
Nako, you had mentioned before the social health information exchanges. Do you sense and do you concur with the challenges of the silos for coordinating care across the different members of the care teams?
Yeah, I do. But I do think, technology only goes so far, right? So we do have states, we have rural areas in our state today that have, the same challenges, but not as much technology. So I do think, back to the facts conundrum, right? If the EHRs aren't there, if the interoperability, if the connectivity isn't there in rural areas of our states, then yeah, I mean, they'll go to the tried and true method. So I do think part of the bifurcation or the compartmentalization of the different data has to do with just physically, distance and high speed internet connectivity, those types of issues, all surmountable. But I think we have to address kind of those issues first before we can start looking at kind of, getting everything electronic, which of course is my goal.
Yeah, and sorry, I'm just going to add one additional element to all this is, we're spending a lot of time behind the scenes trying to standardize all of this information using the terminologies. And so lab, we have this thing called LOINC, and so all the vendors are increasingly, mapping their lab results to this LOINC standard so that we can send this information more readily back and forth. And as Herman said, we can actually understand what the information means and we can actually action on it. Because if I get a fax, I can't trigger a decision support alert on a fax result, but I can if I get a discrete lab value.
Very good. And I think Akko's comments spill great into that next topic on the next slide. Jackie, if you could help us go to the next one. I had a lot of feedback from some of my peers who, especially in the larger health systems, have as part of their caregiving team, delivering especially specialty services for patients that are coming from Nebraska and from Wyoming. And so, Akko, maybe you might be best positioned to talk about what is the future of connecting the interoperability that crosses state lines, because most of the HIEs are state focused right now. So do you have a perspective on that?
Yeah, it's a great question. And so, the beginnings of this started in 2016 when the 21st Century Cures Act was signed, specifically a provision in that legislation called TEFCA, or the Trusted Exchange Framework and Common Agreement. And for those policy folks that want to investigate TEFCA, it's Section 4000 of the 21st Century Cures Act. Talks about kind of putting the patient in the middle of the data. I think it's great when hospital systems, HIEs, and everyone works together, but truthfully, the one person or the one entity that is interoperable is the patient. And so when the feds launched the TEFCA program, they did have that in mind as kind of that way to get data across states. And then of course, in TEFCA, you've got they've adopted the US CDI, or the United States Core Data Set for Interoperability, which sets through some of those standards that Brian was talking about in terms of what data types, what data elements are included in the interoperability formats, as well as ways to securely transmit that data. So, to answer your question about, what's the future in terms of interoperability across state lines, I believe squarely that lies in the TEFCA legislation. And it's kind of like an umbrella hub and spoke type model there's still lots of work that needs to be done in terms of how HIEs and your Epics and your Cerners and your all health systems connect to that. But lots of progress is being made, as well as one of the major provisions for data blocking was also ratified recently in that legislation. So hopefully patients and providers will be able to share data across state lines, but more importantly, it's patient-centered. So no matter where the patient is, that's where the data can be delivered.
So Akko, can we extend a little bit further on that one? Do you think that the HIEs will launch that interoperability between each other, or do you think it will go through the large health systems that drive that?
I think both. So I was on a meeting last week, and a lot of the HIEs are nonprofit entities, and a lot of the large hospital systems. There are also lots of nonprofit and lots of for-profit. But I do think as a utility, the HIE is considered that connectivity point. Of course, I am biased because I work for one, but I do think that in the future, HIEs and hospital systems and large EHR vendors who've kind of created their own HIEs amongst their customers, if you will, they'll all be connected to TEFCA and to that infrastructure. So I'm really looking forward to that, not only for us, but for the patients as well.
Yeah. If you don't mind, Helmut, I'm one of those snowbirds. I spent the winter in Texas and then the summer in Colorado. But so I get a little bit idea of what happens here in Texas as well. And like Akko said, I see the same thing here. In Texas, the public HIEs were not as successful. I think it's also to do with politics and things like that. So in North Texas, the HIE went belly up, and then we moved to the South Texas San Antonio HIE. But we see, like you said, there are private HIEs that start popping up because everybody understands we need to, get the information to the referring physician back from the hospital and things like that. So it's almost like, it's almost like a free enterprise system. We have a strong, some states very strong public HIE. If not, like in Texas, private HIEs come up. And then, of course, there's the vendor network. I mean, there's a lot of people that are on Epic and a lot of people that are Cerner and so many other. There's even so many FQHC, they have their own, own EMRs, and they all connect together. So it seems to be like it's growing and gradually. And the good news is that a lot of these exchanges are based on standards. So even if you have a private HIE, they speak what we call XDS, enterprise, cross-enterprise, document sharing. So if you have a private HIE and a public HIE, and even the VA, DOD, if they have the health information exchange using the appropriate standards with appropriate security, we should all be able to connect. Thank you for,
And so I was just going to add to that, from going back to the virtual medicine space, I have a license not only here, but in the state of California, and many docs have multiple state licenses. So, increasingly as we know, our patients move around, so do the doctors seeing patients in the multiple states. And if we had access to, one central HIE, so to speak, to be able to pull this information out when we're seeing that patient, that would be great. Now, of course, if we could solve the issue that we actually need a separate license in every state, that's a whole other issue, but.
So as we look at, there's this mix of the HIEs versus the mega technology vendor. And I think the feedback I get as I, work with my peers in the industry here in Colorado is that the technologies are mature and they work, but the boundaries are the difficult ones. And so some of our challenges are to how do we really get these behemoths to align well, right? And then as we have parts of our healthcare systems that are the little small guys, and they don't have the big influence amongst the technology partners to affect change. So there's a number of different challenges there. How do we get big behemoths to align? And then how do we allow for the small guys to participate in this exchange information, right? So do you guys see any success stories with how we get these technology vendors aligning? Herman, I'll go with you first. Let's try that.
I don't want to bash any vendors. I mean, we shouldn't do that. But vendors traditionally like to protect the turf. I mean, there's a reason why we have silos, right? I mean, there's silos within, healthcare system, but also silos within vendors. And and I think, I mean, there are some success stories, but there's still a lot of barriers. And if I go back to the interoperability showcase at the HIMSS, I mean, this is the perfect world that you see in front of you. I mean, they have these showcases, and we have Epic and talking with Cerner and talking with the vendors for, I mean, one of the demonstrations, I saw an infusion pump automatically giving the information back to the EMR, and it was great. So I think standards are there, technologies is there, and how now do we break down those silos? There are some limited success stories, but I think there's still a lot of education needed to the providers and say, listen, why can I not take this infusion pump and have, or can I have this contrast, why can't I just have this device talk with the EMR? I saw that at HIMSS. What does it take for me to get my software upgraded to connect? And what does it take for me to have my EMR, if I'm a physician, talk with a big hospital? So I think the success stories I've seen is mostly in demonstrations and some limited, some state levels, but we still have a lot of work to do. And I think it's up to the providers to keep on pushing the vendors because they can do it. It's a matter of deploying it.
Yeah. And to add a different angle to that question, I think, if you step back a little bit, so, at Choreo, now that we are working with the HIE in Arizona, there are some differences, I think, at the policy level. And when I say policy, I think more of a money policy than legislative policy. So, in Arizona, for example, that state is a managed care state across most, if not all, the payers, right? And so they're incentivized to share data because they all benefit collectively from the sharing of that data. Other states may not be as managed care, the fee for service versus managed care difference also creates some silos in terms of the distribution of payment for healthcare in a region. And so I think, in states that are, or regions that are majority fee for value or managed care, the barriers for interoperability between all players, small, medium, large, it's usually a lot lower. And so I do think that, the technology piece it's always been there. We know it's capable of doing it. It's just the will. So I do think across all sectors, across our country, really, if we can align the payment for healthcare with the technology needed to do that, I think that will, grow in leaps and bounds.
And I think we have seen, a little bit of success with things like, Commonwealth, Care Everywhere, Sequoia. But the problem is I just named 3 of them and they don't talk to each other very well. So, we're making some progress and maybe TEFCA will help align these things because as we have been saying, things like Commonwealth and Care Everywhere, prove that the standards and the technology mostly exist to make this work.
So Brian, take that the next step. The technologies and the standards exist. So is this a let's will it to happen? Or do you think there are systemic barriers, whether it be regulation or the commercial aspects of payment and reimbursement?
Well, I like to put my primary care hat on. So up until recently, I was seeing patients in a Centura primary care clinic, which was basically across the highway from Skyridge. So a lot of patients came into my clinic who had been admitted to Skyridge. So in order to get those records, the easiest way that we found was one of our MAs had a login to HCA's Skyridge system, and we would log in and look at the records that way, right? So there is certainly this still competitive angle. These are large hospital systems that compete with each other, and unfortunately, their bottom line is not incented to share this information. But with the regulations, hopefully they're being to some extent kind of forced to, with the 21st Century Cures Act. And sorry, I hope, going back to sort of the notion that Kafka is going to be patient-centric, ultimately, if the patients demand it, if the consumer demands it and insists upon it, like we do with interoperability in our banking and in our shopping and all that, hopefully the actual consumer becomes the ultimate driving force.
Yeah, just Helmut, when we think about success stories, you have to think about, most of my expertise is in imaging. And so what do you do with imaging? You get a CT scan or MRI scan, you get a CD, right? And if you see, when I do my training, I usually ask, so anybody has problems with CDs? And actually asked that question last week. And then I had one of my students say, well, we barely see CDs anymore, because we have this, this great vendor that allows people to upload it, and you have the information. But there will be other IT people that say, well, we see quite a lot of them. And one large institution, actually, they were able to reduce the number of CD interchanges with 50%. And I'm not talking about one of the top big hospitals in the United States. So they were literally seeing thousands of CDs a day, right? They had data, entry stations all over, and they were able to lower that 50%, 50, and just because there are vendors that are taking up this slack, even if there's not a public HIE, then there are vendors say, okay, well, we create a cloud service that allows you to upload the CDs and allows you to seamlessly distribute it to the physician, because they get an email that is encrypted that allows them to have a portal. The same thing with the patient. So there are definitely some success stories, but from what I'm seeing, it's probably 20 to 30%, right? 70% is still wrestling with, like in documents, it's faxes, and in our imaging world is the CD dilemma, right? How do we get rid of CDs, right? To get images across.
I think
so. Helmut, we have a great question from the audience, if you guys want to handle it, and it's right to this topic. So kind of in the perfect world, if we get to interoperability, true interoperability between providers, payers, and the patient, what are your guys' thoughts on the cybersecurity elements of that? So beyond CCDs, CCDRs, if we're talking true integration, we've already have a huge increase of cybersecurity and ransomware concerns. What do you think happens in that world?
If you don't mind, so what are some of the things that we're looking upon, as in the healthcare, where interoperability do relatively well? It's finance. ATM machine can go, I can make automatic payments, banks can exchange information and whatever. So why is healthcare certainly such a target? Because it's an easy target, because we do such a poor job. The hackers don't go after the banks anymore because they're secure, right? They go after healthcare. So if you ask a question, so what do you think about the cybersecurity? If the bank can do it, healthcare can do it, right? So we have a lot to learn. We have a lot to do, and we become much more vulnerable because of the telemedicine increase and all that kind of stuff. but it's not rocket science. Cybersecurity is just a matter of policies, procedures, putting the proper things in place. And then again, that is education. But I'm not worried. If you see some of these big institutions, you should spend about 10% of your IT budget on security. Some actually spend much more. So, okay, that's at least my opinion.
Yeah, and to add to that, I do think when folks start looking at cybersecurity, I think the #1 red flag that pops up is access, right? So now, in order to get data from this other system, I've got to have a 2-factor authentication, smartphone app on my phone. I've got to have a web app. There's many different ways. So I do think, to your point, Herman, that if the banks can do it, healthcare certainly can do it. I do think it's just a matter of prioritization. And I think the more things get interoperable, the more data elements that and the ease to which data can be exchanged between providers, I think the cybersecurity, section will also, it has to increase, because there will be more emails with weird attachments that folks click on that compromise the entire network. So yeah.
Yeah, and I think another way to look at it is a risk versus the benefit. There's always going to be a risk, just as there is in sort of in the financial world. We need to minimize that risk, but the benefits, when I got a patient in the ICU at 2 o'clock in the morning and they come from some other hospital system, the benefit to me and the patient of having access to the patient's medication history and allergies and their problem list outweighs the risk of the cybersecurity. Not to minimize it, but that's part of the equation too.
I think it's a great question, and I really appreciate the input from the audience. Would ask, go ahead and please continue to send in your questions. I think they provide a lot of insight. So we had already talked about LOINC and TEFCA as it relates to standards concepts. I guess I'll ask to Akko first, maybe. What do you think, which of the standards or standards bodies, which organizations or documents do you think are contributing the most value right now?
Yeah, that's a great question. So I do think the continuity of care document, in terms of having that summary for a patient to go back to what Brian was saying about having the problem list, allergies in there. But the interesting thing is, and I think this is where a lot of folks kind of fall off. So we have the standard, but I think there needs to be kind of a re-education in terms of how to put the data in, so that the data can come out. So I do think, I worked with an organization that 500 physicians, multiple locations, and when we implemented the EHR, the provider manual was about a 3-inch ring binder, and the MA manual was like, a 1/4 inch, right? And so we quickly learned that that should be reversed, right? Because really and truly, the care team populates the chart, and the provider comes in and does their thing, right? So I do think that yes, having the standards that are there. So I talked about earlier the US CDI for the CCD standard, but there are lots of data elements in there that are quote unquote standard, but if they're not entered into the correct field to populate that standard, it's just not going to be there. And so I do think that the focus on interoperability is fantastic. It's great, but I also think process improvement in the practice, continual PDSA cycles, looking at the data, and working, putting data in fields that are accessible to the staff, so that they're not clicking, 15 screens away to get to this one data element. That kind of, human design in the EHR is also going to lead to the ability to have richer documentation for interoperability, whether it's the CCD or HL7 standards. Those are just standards. That's just the road that the vehicle travels on. But if the vehicle only has 2 wheels and it needs 4, you're still not going to get anywhere.
It'd be difficult to be on a wheelie all the whole time. Yes, I imagine. Yes, Herman, go ahead, please.
Yeah, so I've been involved with setting standards for many years, DICOM, HL7, IT, and there are 2 things that happen with standards. First of all, the people that write the standards, like myself, I'm not a clinician, right? And so we have this group of people that write these standards, and we might have 15 geeky people, engineering people, and it will be maybe 1 physician. So typically the input for the standards writing by physician is somewhat limited. So we come up with a standard that is maybe not quite what people want. So we learn from that. So Brian said already, the CDA is not quite as useful. And I heard that from so many people, because the CDA, which is, great to have the documents. And like Akko said, people don't always put the data in, but that's made too much. It's an overkill. Right? If you only want to look for the medication, then you have to go for this whole long page of. So it's an overkill. So CDA is so what do we do next, right? So FHIR is the big promise. It's the big promise. A couple of concerns about FHIR. FHIR, we had what we call STU4, which is the 4th release. But within the 4th release, there's a lot of resources, we call them, that are not mature yet. They're not at the level of maturity as we wish that we would have there. So it's a very much in flux standard. But I think the big promise of FHIR is, let's take now the CDA again. We have all that information, right? All that information, we have to browse for it. The big promise of FHIR is that it allows you to identify independent resources that are always up to date, right? So it's almost like you have a website and you click on Google Maps, and Google Maps gives you the latest and greatest, hopefully up-to-date information about the maps, or the weather channel, right? Gives you, what's going on right now. Or there will be, I think about news channel, what's going on with the Olympics, right? You get, the last hour with the medal count. And that's what FHIR does. You don't have to wait for these updates and stuff. It's like a web page which is, consists of all these links that are constantly fed into your system. So now Brian could, have the latest and greatest of information, not only simple things like patient information. I know HCA, I think it's HCA has implemented the patient resource. If the person moved and you open a screen on the EMR and you click on the patient data, you have the information that is up to the second accurate, because it's a centralized patient resource. Now, that's only for the patient information. What about the medication it's on? If a new prescription was fulfilled by the pharmacist, you have that at your fingertips. So I think FHIR, and then again, it's a lot of problems, but I think that's really going to change and take care of some of these CDA limitations and things like that. So, but Brian, I'm sure wants to, we want to hear the clinical perspective.
Yeah, it's funny that we mentioned the CDA, because there was a recent article, I think in Jamia, that talked about, sort of overall the poor quality of the CDAs. And I see that because even when I'm in the telemedicine platform and a CDA is available to me, it just looks incomplete. I ask the same questions to the patient anyway, because I don't trust the CDA, and that's sort of key. I don't trust that it is the complete record. So, and I certainly, we certainly spent a lot of time talking about FHIR, working with the DoD and the VA. We're spending a lot of time sort of thinking about, how can we make things interoperable and adopt some of FHIR? But also, as Herman said, FHIR is not completely there yet. And so we're often saying, well, let's think about this future resource that might be available. But sort of the positive thing is, like working with the VA, oftentimes what we say is, we've got something like 20 million patients. So the VA and the DoD carry a huge stick to not only use the standards, but also drive the standards and improve them. So we can say, look, we think these things are missing in fire. Can you add them? We are saying, hey, these are things that are missing in SNOMED or that are missing in the LOINC standard. Can you add them? So we are seeing that. I will make just a couple of brief plugs here. One is there's sort of like an ancillary fire standard called Smart on Fire. And what that standard is a way to build an app. It's basically an app store. And you can use these plugin apps, and if they work on fire, then they can work in any EMR that supports it. So theoretically, you can build a decision support app that will work whether or not you're using Cerner or Epic or eClinicalWorks. I think we're going to see that over time. Hopefully, these apps will help to make the EMRs a little bit more uniform. And just one other quick thing on interoperability. I see that there was a question on the medical devices. And the only thing that I will say there is that I have been involved in the past with an organization. Sorry, I'm looking it up here. It's called the Centers for Medical Interoperability. It's based in Nashville. It's actually funded by HCA and a couple other huge healthcare systems. And they are spending a lot of time focusing on standards for device interoperability. And sort of the question is, well, how can we kind of get to widespread adoption? Well, if HCA and other large healthcare sites that own most of the hospitals begin to adopt these standards, that's going to help to drive, I think, device interoperability. And that's called Centers for Medical Interoperability. Medicalinteroperability.org is the website.
So Dr. Levy, there is a question kind of, and it goes to what Akko kind of touched on earlier too. And it's a quandary that I've been thinking of a long time because I've worked with multiple EHRs, and it seems like it's a ones and zeros issue. But the question is, what role does information and the information model play on interoperability? So, are we putting in standard information that you can share across? That's going to be an issue, right? And then you kind of hit on it already, Dr. Levy, the terminology of fire, smart on fire, to get that interoperability to work. But if the categories are not the same and the information is not the same, then interfaces don't really help, right?
Yeah, well, certainly that's where we hope the fire standard helps, right? Because that is an information model. And as we said, it's not complete. It's not as complete as HL7 version 2, but it's easier to use and understand. So yes, that does go to a point that I think Herman mentioned. Because fire is not complete, people might use the same fire resource in slightly different ways. They might use the information model in a different way. So you still have discordance there. So we still have education and training to make sure that there is an information model and that we use it in the same way. And we populate it with the standards in a consistent way.
Yeah, but Brian, so here's the advantage of fire. In the old, version 2, we have all this Z segment modifications, and every hospital does something else. So the nice thing of fire is that it's now a requirement that any changes in that, are in part of a capability statement that you can query, and it's in a machine readable format. So you could almost build an on-the-fly compatibility, or on the fly could find out what are the elements that are supported by it. So it's much better. And the other thing I like from the Smart on Fire, and then related to the OAuth, and we talked about cybersecurity. So with Fire having it's like a completely web-based service. There's all those free, I call it free, HTTPS, and all of this free encryption and mechanism that you get. So basically, if the same security that's built in, when you do a little bank transfer on the internet, and it's all secure. We have that with Fire. Last thing I like to mention is device security. The device interoperability. And I work with quite a few device vendors. And let me give you one example: cardiology. Right? Cardiology is probably the most chaotic. I don't know chaotic from an interoperability perspective, because you might have an EKG that spits out a PDF, and another one that does it in XML, and another one that does it in who knows what, right? But that's really, it is changing. It is changing. And here's the good news. It's mostly what I understood for the people like Cerner and Epic, because they said, well, I'm not going to build all these interfaces. There was one cardiology information system, and I said, how many interfaces have you built? He said they have 250 interfaces in his library for all the 250 different vendors. This is ridiculous, right? So there's a big push also from the people like the Cerners and Epic. So listen, we're not going to talk with anyone in cardiology unless he supports either Fire or DICOM. So there's a lot of movement and changes and a lot of pressure on the device manufacturers, right? Because if they want to play in the world of, connect the information to the EMR said, I'm not going to, write another piece of software that is proprietary to the whatever, vendor it is. So that's where there's a big benefit of having a couple of big, organizations, big vendors that tell all the many device vendors, this is how you're going to connect. So,
Yeah.
Akko?
Yeah. So I love this panel. So I think a couple of things from the HIE perspective in terms of, data, whether it be CCD, Fire, or whatnot. I think one of the things that's interesting about HIE is as a person who has had, multiple insurance companies, had to switch providers because my employer's insurance changed, and I've got to go to one hospital systems providers versus another. The one uniqueness I think about the HIE is that all that data typically comes to the same place. So the ability to have that longitudinal view of an individual, whether the data is coming to the HIE via HL7, CCD, Fire, whatnot, at least it's there in one spot. One of the things that we've been working on is we call it a consolidated care summary, or like the CCD, but with the HIE angle, meaning that you can say, okay, I want all the information about an individual for X time frame. So 1 year, 6 months, 12 months, 3 years, right? And we can then take all of the information that we have about that individual and ship it out via API, whether it be our API that we designed, or whether it be Fire, whether it be we put it all together in a CCD so that you get it all. So I do think, as we start to look forward for interoperability and data sharing, I think the HIE is key because we do have that longitudinal record. We do the matching so that the 300 data centers that send us data in Colorado, for example, they all run through the same enterprise MPI. So we are able to then match the various incarnations of people's names and addresses and dates of birth to create that longitudinal record, as well as I think that addresses Dr. Levy's concern with the CCD being empty. It may be empty because it may only come from one data source, right? So I think, connecting to an HIE or an entity that has that breadth of data and then being able to say, okay, for the emergency use case, I'm really only interested in the last 6 months of data. And give me just a summary of all the information you have for the last 6 months. On the topic of device interoperability, I do, I'm looking at the US CDI, United States Core Data Set for Interoperability. They're starting to get there. I believe right now they're only doing unique identities for implantable devices. So there is some work that's being done, but it's not in the standard. But to Herman's point, I do think that once the larger vendors, device vendors start to work together, they can certainly lobby US CDI to start including some of that information.
So guys, we're about to approach the end of our time, and we definitely said that we'd provide a short bit here for people to ask questions. So I'll ask, again, for the rest of the audience, if you, it's great to have those questions already. If you want to step into any other questions, I'd appreciate it. And I know that Jackie's going to make a plug for an upcoming event. But so while we're waiting for any more questions to come in, maybe just one final one, if you guys can give your just 1 or 2 sentence response about which regulation do you think that's coming down the path should everyone be watching out for? And maybe Herman, if you want to start.
Yeah, I think the anti-blocking rule. I mean, I think there had to be. It was part of the I think legislation in April, and I think people are getting a little bit nervous because it's, to my understanding, correct me if I'm wrong, but to my understanding, there's no penalties yet being to defined, and there's no stick behind with the carrot, but hopefully we talk about this interoperability issues and how could we change this, and hopefully the anti-blocking rule will be at least a little bit of a nudge for some of the providers to start sharing that information, even although it might not be financially beneficial to them.
Very good. Brian, do you have one or two that you'd want to suggest people watch out for?
Yeah, well, I think one, putting our Colorado hat on, we have our updated state healthcare IT roadmap, which has a lot of interesting things in it. Talks about social aspects of healthcare and sharing that, talks about HIE. So I would say, for all those folks here, take a close look at that. And, we're going to hear a lot more about this Colorado Health IT roadmap at future Colorado HIMSS events. So that would be my one plug.
And Akko.
Yeah, for me, I talked about this prior, but and of course, Herman took my answer for the data blocking rule because I think that's huge. But I do think the whole idea of enterprise indexing of individuals, identifying the data from interstate, out of state, for interoperability is going to be huge. And I know TEFCA is addressing that. I think it's probably a little smoke and mirrors right now, but I'm looking forward to digging in and seeing how that's going to work, because obviously, if we don't address the identity piece, then I think it was Google and Microsoft started with their interoperability or their patient data hubs, I think is what they call them, and they failed miserably because of identity and, of course, the sheer volume and inconsistency of the data. When folks started looking at their records, they're like, it says that I have hypertension. Well, I've never had hypertension, right? How do I fix this, right? So I do think having the correct matching and quality assessment of data is going to be a key.
Well, guys, thank you so much for your great insights today. I think they were very practical to Colorado, but also what we're doing across the nation as our healthcare system continues to expand and our connectivity. I'm not sure if we have one more question that might have come in.
We do, and I think it's a great one to end on because it's a little controversial and a little fun.
Yeah.
And you guys hit on some of this earlier, but should the onus of responsibility be on the care providers, the clinicians, and the end users, or should the onus of responsibility be on the EHR vendors so that interoperability and standards can be followed? Because there is a ton of push, and you guys mentioned it. Are we educating our staff correctly? Are they documenting correctly? But for me, putting my clinician hat on, a lot of the gems in a medical record are the pros, right? It's the clinical documentation, the written documentation, the dictated documentation, and some of those nuances are missed regardless of standards and regardless of how the EHRs are built.
In fact, HIMSS has a work group, I think it's called the Patient Story Work Group, and it is talking about that exact issue of how do we share and develop standards for sharing that pros, because you're right, oftentimes, and this is, I think, in part why the CDAs can not be so helpful. Oftentimes I need to know, what was the doctor thinking? What was their assessment of the patient? Was this patient sick or not? And we don't get that when you just look at the discrete data.
Herman.
I don't know, but I don't think, sometimes I think we blame the vendors a little bit too much. many years
Is there
ago.
such a thing? I'm not sure.
Yeah, so when we had this big thing with the Ebola here in Dallas, the first thing was to blame the vendor. And I'm not going to mention the vendor, but he said, well, and it was really, the vendor provides a framework and a template. And the fact that the Ebola at that time was missed was because it was a, incorrect, setup, or actually a configuration. And that's actually, again, the user. So I think it's really a lot of responsibilities back to the user and the providers.
Last word, Akko.
Yeah, I think it's a little bit of both. I think, from my EHR implementation days, there's a lot of good things there. There's a lot of configuration and testing that needs to happen beforehand.
I know.
So vendors can only go so far. That's why they say the EHR is yours. You get to customize it, right? And so how you customize it and smartly, and of course how they code it is a little bit of both. So I do think both sides share the blame or the opportunity.
Well, you guys definitely danced the politics of that perfectly. It is amazing the expertise that you guys have brought to the panel today. Very much thank you. We've reached our time limit, and I'm pretty sure, Jackie, if you want to give your plug here, and then know about how they can get access to the material for this presentation.
Thank you so much. And panelists, my goodness, thank you so much. What a great conversation. And we welcome you back anytime. Maybe next time we'll talk about cybersecurity. So thank you so much. Helmut, thank you so much for putting together a great webinar, a great panel. And Dr. Levy, I'll put a plug in for our HIMSS Advocacy Day coming up on Tuesday, April 26th. I think people should join you for that.
Yeah, hopefully we'll be in person. That's our plan. So to
Exactly.
actually see people in person.
Exactly. Thank you. And we will be sending out the recording for this, as well as the PowerPoint slides for your use. Please, if you have any questions, please just email our Colorado HIMSS email. Any of us would be happy to answer your questions. So thanks again. Have a great rest of your week. And thank you for joining us today.